The NHS's proposed purpose of ICSs is to bring partner organisations together to, number one, improve outcomes in population health and healthcare. Number two, tackle inequalities in outcomes, experience and access. Three, enhance productivity and value for money. And four, help the NHS support broader social and economic development.
They come out with sort of like their ambitions to sort of improve the health and well-being of the population,
Yes.
overall quality of care and life, and improving the effective utilisation of resource.
Yeah.
So I suppose those are sort of the main things that have sort of come out. And I suppose sort of if you're looking at use of medicines, it's sort of trying to look at sort of quality and safety culture around the use of medicines. So we're sort of trying to work, to improve with them patient outcomes. And then you're sort of looking at unwarranted clinical variation. So you're trying to reduce that with medicines and looking at equitable access. Again, I say working in collaboration with your system partners and trying to sort of, I suppose, gain the maximum benefit for what you're spending, really.
Now, the ICS leads that I spoke with are broadly aligned with the purpose of the ICS, but some have reservations about how they can support social and economic development within their populations. So the main benefit that virtually all highlighted is the ability of ICS organisations to work and make decisions at scale and therefore use collective power as a positive means to leverage further efficiencies within the system. Now, significant opportunities exist for ICSs if they can industrialise and standardise.
The foundation principle of it is it's better to do things at larger scale and make decisions at larger scale by working with partners from local authority than it is by operating your leadership at smaller delivery groups like places. Places would be size of a CCG or 2 CCGs. That's the principle of it. You raise everything up to a higher level. You make your big buying and commissioning decisions once across multiple geographies, and you get industrial scale benefits from doing that. That's the principle of it.
Scale is exciting. It's got opportunities, and there are economies of scale for workforce and recruitment and career development and so on. But scale is also a bit of an enemy of delivering tailored care, and easily risks becoming a bit of a faceless bureaucracy.
Secondly, the ICS structure promotes a system-wide view when applying logical, scientific approaches of how to get things to work better.
Probably the biggest challenge for most health and care economies in England is how do you deal with frail people. It's not people like you and I. We might get ill every now and again, or you might sort of fall off your back and break your wrist. It's not that type of thing. It's mainly, not always exclusively older people, but mainly older people who get to a stage in their life where they aren't sustainable on them by themselves, and they just things happen to older people that don't happen to younger people. So they get ill more often, they break things more often, their infrastructure collapses. Now, that is the biggest problem, because at the moment we've got no structured way in which we approach the care of that very, very large cohort of people. That cohort of people consume around about 65% of all care resources in England. So if you're over 70 and you've got one or more chronic condition, you lump all those people together and they consume 70% of all the taxpayers' resource in the health service. And yet we don't have a structured approach to how we mitigate the risks of those people. We've tried, but never succeeded. So by working as an RCB, together with local authority, we could say, right, okay, we know what the biggest problem is. The biggest problem is this cohort of people who, if they've got good care infrastructure, we might mitigate the year of care cost reasonably well. If they haven't, we're all going to spend a fortune. So they're going to go to hospital 6 times a year. Every time they go in, it's going to cost a fortune. We can't get them back out again. Eventually, they will need to go into a residential setting, and that takes ages. And we got bed blocking and all that sort of stuff. Add it all together, costs a fortune. So how would we manage that cohort of people better? by combining our wits and our money and our resources and people, and structure a year of care plan for every single one of them that's industrial scaled. So it's not completely individual for each one. The platform is exactly the same, it just got some nuances.
Yeah.
So we don't have to think every time we get somebody like that who enters the system, what do we do with this person and make it up as we go along? It's all pre-planned.
So this new way of working as a system also enables innovative ways of delivering care for the community. And the NHS has proven time and time again that necessity can be the mother of invention when resources are scarce.
It is a sort of new start, and it's up to us to make what we can of it. And shortages of money often bring out the best at the NHS of thinking about how do we make, you know, what little we've got go further. I think there are some big planks emerging. Health inequalities, the variation in clinical outcomes, and beginning to think about communities as groups of population that, you know, so not just thinking about a borough and a local authority and a joint strategic needs assessment, but beginning to say, okay, each local authority has 10 major communities, which may be geographic, but may also be cultural, may be economic. How do we respond to those different needs? And some of those communities will overlap, of course. So, you know, right now, part of winter planning, of course, what, you know, we're thinking about, well, how do we provide warm spaces for people at risk with their energy bills? What else could happen in that warm space? Could there be health advice? Could there be benefits advice? And how do we make those messages to communities more relevant?
Let's talk a little bit about population health management, as population health is a term you'll frequently hear bandied around with ICSs. So it's certainly not a new idea, but it's a core strategic aim of the ICSs. The problem is not everybody is exactly sure what it means or what it truly involves.
I think population health management means lots of different things to lots of different people. Well, you know, one of the problems is a common definition. I mean, I think for me, it simply means understanding your communities and your local populations in more detail.
Our health system has traditionally been based on being a reactive service focusing on individual conditions. Now, ICSs aim to embrace a proactive approach by identifying and engaging with those high-risk groups earlier and bringing them into the health system.
With proactive care comes preventive care, which you know, we've talked about for an awfully long time and have done bits of. Maybe again, when finances are tight, maybe we can start doing a bit more of that and building on what we've done already through diabetes, or obesity, or respiratory, or child oral health, or whatever.
Now, prevention being better than cure is a fundamental principle of healthcare. And as an example, in a population health management context, adults and children who live in cold, damp housing may be more susceptible to developing respiratory problems over future years because their lungs can be affected by mould. Now, if their housing situation could be improved earlier by working with partners such as local councils and housing associations, they may not end up with health conditions such as asthma, chest infections and other respiratory problems in the future, which can result in poor quality of life. Now, understanding the social factors that contribute to these comorbidities within these populations could avoid the need for multiple health and care services, which in turn helps address health inequalities.